So, Bismillah Rahman Rahim. Assalamu alaikum to all of you. My name is Rehana Ilahi. I'm Director of Nursing for Shaukat Khanum Memorial Cancer Hospitals. And on behalf of Organizing Committee of the Symposium and Nursing Division, I welcome you all to the prestigious event of Shaukat Khanum Memorial Cancer Symposium, as well as the second session of nursing, oncology nursing. And like yesterday, inshallah, we'll have a very, very gracious, enlightening, and enjoyable session. Please stay with us. So to start the program, I would like to call Ms. Lubna Ghazal, the Associate Director of Nursing, Shaukat Khanum Memorial Cancer Hospital, currently in Lahore, but inshallah in future, the Associate Director of Nursing for Shaukat Khanum Memorial Cancer Hospital, Karachi. So a big round of applause. And our second co-chair is Mr. Adnan Yaqub. You have met him yesterday through the talk. Our principal, School of Nursing, Principal Education, Shaukat Khanum Memorial Cancer Hospital. Please, a big round of applause for him. And with this, Ms. Lubna and Adnan, we officially initiate our program. Thank you.
Thank you so much. Yeah, let's start our session today with the verses of Quran. And for that, I would like to call upon Mr. Irfan, who is manager OR at Shaukat Khanum.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفر إنه كان توابا तर्जमा शुरू अल्लाह के नाम से जो बहुत मेहरबान रहमत वाला है। जब अल्लाह की मदद और फतह आए और लोगों को तुम देखो कि अल्लाह के दीन में फौज दर फौज दाखिल होते हैं तो अपने रब की सना करते हुए उसकी पाकी बोलो, उससे बख्शिश चाहो, बेशक वो बहुत तौबा कबूल करने वाला है। सदक़ल्लाहुल अज़ीम।
Jazakallah. This is with great pleasure. I would like to introduce our respectable first keynote speaker, Professor Naishui Kui. And she is a PhD prepared nurse. She has completed her PhD from the University of Pennsylvania, USA. Currently, she is an associate professor at Shandong University, China. She is a renowned researcher in the area of children and adolescent mental health. And with her special expertise in the quantitative methodology and advanced statistics, Dr. Kui has published several papers in high impact journals. So, Dr. Kui, over to you.
Thank you. Thank you for the introduction. Good morning, everyone. It's a great pleasure to give my second presentation on implementation science, bridge the gap between research and practice today. So this is the outline of my presentation today. First, I would like to introduce a little bit historical background of this field of research. So I think we're all aware that there is a great failure to translate findings into clinical practice, and this is consistent across many countries, suggesting this is a very difficult problem to solve. Actually, this may be a fundamental challenge of healthcare system to optimize care outcomes and costs, and we need to think about how can we do better. In the same time, there is a very famous paper published by Zoe Morris in 2011. They reviewed several papers and identified it takes 17 years on average to translate research findings into practice. And this absolutely is not optimal. And researchers are thinking about how can we do better. So this comes implementation research or implementation science. In 2006, the journal Implementation Science was launched, and the editors-in-chief, Professors Eccles and Maitman, defined implementation research as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice. In order to improve the quality and effectiveness of healthcare services. And this definition is still valid today. Looking at the definition, you may feel familiar, right? But you may have seen this kind of definition, but use different terms. And you are absolutely right. So in 2008, Tetral and colleagues did a review study about the terms used to describe implementation, and they found a lot of similar terms to implementation, such as knowledge transfer, knowledge translation, research translation, transmission, and you may be familiar with these terms. Actually, these terms shows the evolving conceptualization of implementation science. But usually they have a slightly different meaning. For example, knowledge translation is the process by which research is created and translated into practice for the purpose of improving healthcare and health outcomes. So both knowledge translation and implementation science aim to bridge the gap between research and practice. But knowledge translation is more about ensuring that knowledge users are aware of and use research findings in their decision-making, while implementation science studies the black box between research and practice to understand how evidence-based interventions can be successfully integrated into practice. And I visited your hospital the day before yesterday. I was so impressed by your projects on quality improvement. You have done absolutely wonderful job on this. So it triggers me to think about the difference and similarities on quality improvement and implementation research. And Professor Tyler and Glasgow did a very good job to summarizing these similarities and differences in their paper. For example, both quality improvement and implementation research or implementation science has the same end goal, that is to improve health outcomes, but they have some differences. For example, quality improvement originates from industry, and implementation research has its origins in behavioral science and health services research. And they have other similarities and differences as shown in the figure. So, quality improvement usually starts from identifying and understanding the problem. And then they use the famous PDCA or PDSA cycle to identify a solution. But implementation science starts from the solution, which means the solution is already there. That's evidence-based intervention. But the problem is not practitioners don't implement this solution in clinic. So that's the implementation problem. And then they goes on this circle to implement the solution, spread the solution, and sustain the solution. So we'll give you an example of implementation problem from my own experience. So me and my master student wanted to do ischemic intervention among hospitalized children with leukemia. We started thinking about last year, and we wanted to launch this intervention in hospital earlier this year. We were motivated to do this because we are aware that children with leukemia suffer from a lot of conditions beyond the disease, such as cancer-related fatigue. And there is good evidence showing that physical activity is very beneficial to these children. And we conducted a survey study among children with leukemia last year about their screen time, which is one of my research focuses. And we found that these children, the average screen time among these children is 3.2 hours per day, which is much higher than school-going children. That is just 1 hour per day. So physical activity is a good displacement of screen time. So we think physical activity is very suitable for these children. And we interacted with parents and children, and they all expressed their interest in participating in physical activities if doctors say it's safe to do so. And we chose X gaming as the activity of as the form of physical activity because we think it's fun, it's easy to engage children, and it can be sustainable. And we also did a scoping review and found that many studies shows X gaming has the same benefit, produces the same benefits as regular physical activity in improving children with cancer's physical function, sleep, as well as cognition. So I think we have a brilliant idea. We are very excited about this. And in the meantime, in our scoping review, we found that most literature on X gaming among children with leukemia was conducted in the Western. They use Switch or Xbox as the equipment for X gaming, which are very expensive. We found an alternative. There is a Chinese app called 天天跳绳, which the literate translation is jump rope every day. It has X gaming feature. Let me show you a game in. So it used the phone's camera to capture the body motion, and we use the body motion to control the movement of the figure in the game, so we can complete a task. So it's free, it's fun. So we proposed this to practitioners in 3 hospitals in Shandong province, and we got a lot of concerns. Because many children, many patients have this chemo port or PICC in their body. So they were very concerned about when they move, when they do this physical activity, the catheter may be blocked or dislodged. Then we told them, we are going to just choose the activity using the lower part of the body. We don't want to them move the upper part of the body. But then they said, what if they got infected? Then we say we're going to sterilize everything before the activity and after the activity. And then they say, what if they fall or they get other injuries? Then we say, we will put like foam pads on the floor. We will have assistants to monitor everything. We also got a polar watch to monitor children's heart rate to keep them safe. But still, we got firm no. So this is absolutely an implementation problem because we have good evidence to support that physical activity is safe and beneficial to hospitalized children, even during their treatment. But practitioners just don't want to implement this because they have so many concerns. I have another example, but I think you have done a wonderful job on this. This example is about hand hygiene, so I just skip it. So how do implementation science address these implementation problems? So first, they use a lot of theories, models, and frameworks, which is a unique feature making implementation science different from quality improvement. So Nielsen, in 2015, Professor Nielsen summarized all the theories, models, and frameworks used in implementation science and categorized them into 5 groups. They are process models, determinant frameworks, classic theories, implementation theories, and evaluation frameworks. So process models describe the process of translating research into practice, such as the knowledge to action framework and the French model, which I will talk about sooner. And determinant frameworks describe the factors, the typical factors that are hypothesized or have been found to related to implementation, such as the consolidated framework of implementation research, SAFER for short, and the theoretical domain framework, TDF. Implementation researchers also borrow a lot of theories from other disciplines, such as psychology and sociology. They categorize this as classic theories, such as social learning theory. Implementation theories help us to understand the fundamental how and why of implementation question, which means how we implement something to improve to solve the implementation problem and why we use these strategies, such as the capability, opportunity, motivation, and behavior, COM-B theory. Evaluation frameworks refer to those that we can use to help us evaluate the implementation outcomes. The very famous one is RAIM, which means reach, effectiveness, adoption, implementation, and maintenance. So here is an example of process model, which is the French model. This model was proposed by French in 2012. So they classified implementation process into 4 steps. So the first step is to identify who needs to do what differently, whose behavior need to change, and which behaviors, what's the evidence supporting this. The second step is to identify factors determining whether or not they do it. What are the barriers and what are the facilitators? Step 3 is which strategies can be effectively used to target these factors. Step 4 is how can we evaluate the outcome. I will give you some examples toward the end of my presentation. So any questions here? No? Okay, excellent. Because I'm going to talk something kind of confusing to beginners. That is the difference between effectiveness research and implementation research from the perspective of implementation science. So implementation scientists categorize intervention study into 2 categories: effectiveness research and implementation research. So effectiveness research focuses on the effectiveness of interventions. By interventions, I mean treatments, diagnostic procedures, preventive procedures, counseling techniques, devices for patients. Implementation research also focuses on the effectiveness of interventions, but these interventions are called implementation strategies. For example, educational, organizational, financial, or technical activities. Sorry. And these two categories of research have different focuses on outcomes. So effectiveness research focuses on the effectiveness of interventions on individual or service outcomes, such as incidence rates, mortality, quality of life, equity, efficiency, etc. But implementation research has implementation research focuses on the effectiveness of implementation strategies on implementation outcomes, including acceptability, adoption, cost, feasibility, fidelity, penetration, and sustainability. So these are different outcomes. But I don't know what happened. But we can do effectiveness research and implementation research together, which is the hybrid designs. There are 3 types of hybrid designs: type 1, type 2, and type 3. So type 1 primarily focuses on the effectiveness outcomes, while exploring the implementability of the intervention. So type 3 primarily focuses on implementation outcomes while collecting data on effectiveness outcomes because it's relevant to uptake and fidelity of the intervention. And type 2 has a dual focus on both effectiveness outcomes and implementation outcomes. So we can testing both outcomes in one trial. If you are interested in this hybrid design, I highly recommend this paper. So they did a very good job in explaining the 3 types of hybrid designs. But I'm not going to talk the details. And I would like to do some fun part. Example of implementation research. So I purposefully show you the article of implementation research following the steps of proposed in the French model. This is not how researchers describe it in their paper, but it's just me doing this to help you understand this. And sorry for the busy slide. I just want to keep as much information as possible to enhance the understanding. So this example is about implementation of a hospital-wide multidisciplinary blunt chest injury care bundle, CHIP. So let's see how they did it. Step 1, a refresh of the French model. Step 1, who needs to do what differently? Let's see how the researchers, the authors explain this. So they said blunt chest wound injury is very common, and if effective or delayed treatment can result in high morbidity and mortality. And the use of guidelines for blunt chest injury has been shown to be effective. But the problem is that the compliance with guidelines was not optimal, and the compliance rate was just 55 to 58%. So there is a implementation problem, right? Who needs to do what differently? It's the practitioner needs to improve their compliance with the protocols, right? The second step.
Professor Kui, why don't you use the, that's fine.
It just skips pages. Okay, thank you. The second step is to identify factors determining whether or not they do it. So they conducted a mixed method study among 441 staff from 2 participating hospitals using the theoretical domains framework as the theoretical foundation, which is a determinant framework, right? We just saw this. And they identified 9 facilitators and 6 barriers. You don't need to read all the table, it's just too much. I just want you to know what they did in the second step. And then based on these factors, they identified strategies to be used to target these factors. They developed a multifaceted implementation plan containing 7 intervention functions and 15 behavior change techniques based on the behavior change wheel. If you know evidence-based practice, you must know the behavior change wheel method is quite widely used. And they also develop an evaluation framework called APPEASE, which stands for affordability, practicability, effectiveness, accessibility, side effects, and equity. So they will evaluate all these outcomes. And their intervention target is to change the behavior of staff involved in the activation of or response of CHIP. Okay, then step 4. How can we robustly measure the outcome? In order to measure the outcome, they did a pre-test. They designed this pre-test and post-test study over a 4-year period. In this paper I cited here, they reported 3 outcomes that are reach, fidelity, and dose. Reach means whether the intended patient group received the care bundle activation. Fidelity means if chip was delivered as intended. And dose means the adherence to the intervention components. And as we can see in the results, all outcomes are improved significantly. And this is how we do implementation research following the 4 steps. Okay, there is another example which is about non-pharmacological interventions to promote gastrointestinal function recovery after surgery for gastrointestinal cancer. This project is led by a nurse team at the Second Affiliated Hospital of Shandong University. This is an ongoing project. It's still in process, but I just want to share some of our insights. So the background is that post-operative patients with gastrointestinal cancer often experience many dysfunctions such as nausea, vomiting, pain, and bloating. We can use drug to treat this dysfunction, but it increases risks of cardiovascular diseases and complications. So non-pharmacological interventions are favored. So the team summarized some best evidence from guidelines, expert consensus, and systematic reviews. So we got 10 points of best practice, and I listed here. You don't need to read all of them because this is the important part. After we synthesized all the evidence, we did a screening. Among the staff in this hospital about their adoption of this practice. As you can see from the very left column, the adoption rate is not optimal. Many points were not adopted at all. So this is an implementation problem. So we are going to solve this problem based on implementation research. So we are going to, actually this is in process. We are doing a qualitative interview study to identify barriers and facilitators influencing the adoption of this best practice. And after we have done this, we will develop implementation strategies and then conduct a hybrid type 2 trial to evaluate the if practice and patient outcomes can be improved. Okay. Sorry. Okay, that's implementation research. There is another field in implementation research. It's called de-implementation.
I think if you just use the slide changer.
Yeah, okay, that's okay. I almost finished.
Yeah.
So it's called de-implementation. So as important as implementation, sometimes it's important to stop use practice that is not supported by evidence. That's called de-implementation, which is to avoid low-value care. And the common strategies of de-implementation is substitution and is disenchantment. And I will give you an example on this. So this is an example on sustainable de-implementation of continuous pulse oximetry monitoring in children hospitalized with bronchiolitis. And I also decomposed the paper using the 4 steps proposed in the French model. So step 1, who needs to do what differently? So the authors stated that these patients are often continuously monitored with pulse oximetry, despite evidence shows that it doesn't really improve outcomes for certain patients. And continuous monitoring may identify some brief self-limited dissertations that don't necessarily require treatment. And overuse of this monitoring is associated with many adverse outcomes, such as increased administration of oxygen, prolonged length of stay, and increased cost. So this is a low-value care, and we need to stop or reduce the use of this. So the second step, that's okay. So the second step is to identify factors determining why they keep doing this, right? So these are the key barriers they identified from their study. Educational gaps, lack of clear instructions, and culture that normalize this monitoring. So the third steps is how can we, what strategy can we use to target these barriers? So they can convince 39 stakeholders from hospitals to develop de-implementation strategies. They also did this based on theoretical framework, which is the feature of implementation research. The strategies they adopted is unlearning and substitution. So they use educational outreach with audit and feedback for unlearning, and they replace continuous monitoring with intermittent remeasurement as a strategy of substitution. And how they measure the outcome? So this paper is a protocol of how they are going to evaluate the outcome. But before this, they have done a pilot trial in 6 hospitals, and they found that the adoption rate of this low-value care decreased from 53% to 23%, so a huge drop. And more than 90% of physicians and nurses think it's feasible and the deep implementation strategies are feasible and acceptable. So they are going to scale up this study using a type 3 effectiveness de-implementation cluster randomized trial. And this is how they map their final RCT. Okay, so that's all for my presentation. So the take-home message here is implementation science is the scientific study of methods to promote the uptake of evidence-based practice. It can be regarded as a methodology of knowledge translation or evidence-based practice. Its unique feature is it has many theories, models, and frameworks. So it conducts every step based on these theories, frameworks, and models. The objectives of effectiveness research and implementation research are different, but they can be integrated using the hybrid designs. And de-implementation is also sometimes it's very important to avoid low-value care to improve our health service quality. And these are the references. I have resources. I recommended the resources. If you are interested in the field, I recommend these resources to find more information on this. And thank you.
Thank you, Professor Kui. And I think if I summarize what we have learned today, I think this presentation was quite relevant to us because we do a lot of quality improvement projects. And through this, we have, I think, able to differentiate what is the difference between quality improvement projects and implementation science. And another new concept for many of us was de-implementation. So I think we should look into our quality improvement projects. Maybe we are doing some de-implementation. So let's review and move forward. Thank you, Dr. Kui.
So our next keynote speaker is Dr. Shelley Nolan. She is a PhD nurse and serving as the Chief Nursing Officer for Queensland, Australia. She is internationally recognized for her nursing leadership through her involvement with the World Health Organization and the International Council of Nurses. She is also an adjunct professor and has numerous reputable publications to her credit. So please welcome our next speaker, Dr. Shelley.
Good day to you all. My name's Shelley Nolan, Chief Nurse Officer, Queensland, Australia. Today, I would like to speak with you about advanced practice and nurse-led initiatives here in my state. The Office of the Chief Nurse Officer respectfully acknowledges and recognises Aboriginal and Torres Strait Islander peoples as the traditional owners and custodians of the lands, winds and waters where we live, learn and work. We pay our respects and acknowledge the important role of elders past and present and into the future. Today we are meeting in Meerjin on the lands of the Turrbal and Yagara peoples here in Brisbane. Queensland Health is made up of 16 hospitals and health services, and each of them are independent statutory authorities. We align with the Department of Health as per the slide. We have a very large state, as you can see, and it is one of the largest states in Australia compared to others. With large geographic diversity, where often the only care provider is a nurse. We have a career classification structure that support the profession of nursing. In Australia, we are regulated by the Nursing Midwifery Board of Australia, and we have an advanced practice role, which is a nurse practitioner. However, there are 3 other types of nurses that also can have advanced practice supported in their roles. These are the enrolled nurse and registered nurse and the nurse practitioner role. The Australian nursing workforce continues to be undersupplied. An ageing workforce, relative attractiveness of the profession and alternative career opportunities are principal factors to supply. While an ageing population with greater expectations of health services is increasing demand. Key strategies here in our state that underpin the National Nursing Workforce Strategy and the Queensland Health Work Strategy for Queensland in 2032. We will aim to ensure an adequate supply of nurses and enable them to work to their full scope of practice in our clinical roles. The importance of this is about satisfaction, and if nurses are satisfied with their work and particularly can work to optimal scope of practice, they're going to be retained. The Nurse Practitioner Nurse Endoscopy program was previously run in 2016, and 8 graduates are from that program. 7 of these graduates are still practicing in Queensland with exemplary outcomes for their service and key performance indicators, patient experience, and quality and safety. The program exemplar was published by the Office of the Chief Nurse and Midwifery Officer in 2020, along with other nurse-led models. The success of the Nurse Practitioner Nurse Endoscopy program in Cairns has more recently been the topic of our media. To ensure nursing roles are supported to advance their scope in our enterprise bargaining agreements are negotiated between unions and government. We have jointly agreed to conduct a scope of practice project for nursing. It has been undertaken through town halls and surveys with our registered nurses, nurse practitioners and enrolled nurses to address barriers, structural and identify key areas that can enable the supportive foundations for good clinical governance to allow nurses to advance to their full scope of practice. Such barriers are legislation, policy and standards, our college guidelines, credentialing, academic, and also the culture within our profession and how we are supported by other disciplines such as doctors and allied health. There's also custom and practice and the care point of difference. All of these barriers, with suitable discussion, can be changed to become enablers to support nurses to work to an advanced practice. The Therapeutic Goods Act adopts the Australian Therapeutic Goods Act and regulation as law in Queensland. This means that these Australian laws will now apply to persons to whom it may not have previously applied, namely sole traders who manufacture medicines for sale only within Queensland. The Medicines and Poisons Act includes many offences that require people to deal with substances in an authorised way. For our profession, these substances are medicines and poisons governed under the Medicines and Poisons Act 2019, and there's 3 regulations under it. The Medicines and Poisons Medicines Regulation, Poisons Regulation and Pest Management Regulation. The regulations establish the rules for the authorised ways to deal with medicines and poisons. In this way, the regulations complement the Act by authorising actions that would otherwise be unlawful. This is important to advance practice roles. In addition to the regulations, some of the more prescriptive controls that were previously under the Health Drugs Poisons Regulation are now expressed as outcome-based standards. Some examples of standards include the Electronic Prescription Management Standard, the Storage Standard, and in some instances, the regulation of standards may defer to other established frameworks. The Electronic Prescription Standard, for example, recognises the National Conformance Profile for Electronic Prescribing and Dispensing Systems. The regulatory framework applies to persons carrying out regulated activities with regulated substances and affects a broad range of stakeholders across industries as diverse as agriculture, healthcare, pest management, and veterinary services. As I mentioned, in this case, this relates to trained health professionals, which in the right authorities expressly defined in the legislation to deal with specific medicines in certain environments and in particular cancer care. Optimising and advancing practice through legislation provides an extension to what an approved person may do under the medicines regulation. Arrangements for the administration and supply of medicines by nurses and midwives without a prescription is taken up via an extended practice authority. Practice is supported by health management protocols, and we have 4 parts. Part A is specified services to address health and community need. Part B is services in rural and isolated practice areas. Part C is sexual or reproductive health services. Part D is immunisation program services. We've made recent amendments, such as the Extended Practice Authority for registered nurses, and it now includes the addition of vaccines, broaden locations where registered nurses can administer vaccine under the Extended Practice Authority, Part D, addition of long-acting reversible contraception, update to contemporary medicines for sexual and reproductive health conditions, amendment to the education requirements for rural isolated practice registered nurses and sexual and reproductive health nurses, and nurse practitioner prescribing unapproved medicines. We are also exploring several other types of amendments. So why is this important to discuss with you? If we have place-based care supporting cancer care and we want our nurses to work to their optimised scope of practice, it also means providing therapeutic treatment doses and managing medicines to support the treatments. The number of Queenslanders diagnosed each year with cancer continues to intensify, along with levels of complexity of their disease. The ongoing variations and introductions of new treatment pathways available and the care and support the cancer patients require for survivorship from diagnosis. The advanced specialist knowledge and skills required to manage and care for cancer patients within the hospital or home setting is in demand, now more than ever across regional, rural, remote and metropolitan hospitals across our country. The Cancer Care Strength with Immersion program priority of deliverables was to support the Queensland cancer care nursing workforce to attain their professional goals by expanding clinical skills and theoretical knowledge while gaining the confidence and competence required to assess, plan, implement and evaluate care of the patient with cancer diagnosis holistically while focusing a professional culture that promotes engagement and partnership within our communities. The 2024 Cancer Care Strength with Immersion program was the first of its kind within Queensland clinical cancer care. It was sponsored by the Office of the Chief Nurse Officer to develop Queensland Health's cancer nursing workforce. The program was coordinated by a specialist cancer care nurse educator based at the Royal Brisbane Hospital and Women's Hospital, and all learning experiences were facilitated in collaboration with the Royal Brisbane Women's Hospital Specialist Cancer Care Nursing Team. The primary objective was to provide an individually tailored, accelerated learning program and an experience within dedicated cancer care services at the RBWH. Theoretical and clinical components of the Strength with Immersion program included anti-neoplastic drug administration training and assessment, central venous access device training and assessment, stem cell collection and therapeutic apheresis procedures, care of patients undergoing chimeric antigen receptor T cell and hematopoietic stem cell transplantation, acute and chronic illness management, hypersensitivity reaction management, and management of the deteriorating patient. To meet the wide scope of learning objectives submitted by participants, stakeholders within the external to cancer care service line were engaged, including operating theatre, breast care clinic, radiation therapists, educators, physicists, cancer care coordinators, clinical nurse consultants, nurse practitioner, blood management clinical nurse consultants, and nurse educators. The additional support and exposure to internal and external nursing specialties was strengthened and solidified the success of participants' learning objectives overcome. At project close, 15 immersions were successfully completed. 2 participants attended anti-neoplastic drug administration course workshops, and 2 participants attended the service line's first cellular therapy workshop. Cancer care nurses are assisted to develop the necessary knowledge, skills and abilities to facilitate their practice as a competent cancer care nurse, providing a foundation to specialisation and effectively function within a multidisciplinary team or independently for a range of issues in a variety of cancer care settings. The cancer nursing program has been developed within the context of contemporary cancer care practice and provides a structural process through which the core knowledge and skills of cancer care nursing are developed. The program promotes the unique needs of the cancer care population and supports optimal patient outcomes through the development of safe and competent workforce. The program provides a coordinated and consistent approach to the provision of clinically focused post-registration continuing professional development to support the extension of theory to practice. The program aims to provide Queensland Health registered nurses with post-registration clinically focused education programs that utilise principles of adult teaching and learning to promote lifelong learning. Provide Queensland Health registered nurses with equity of access to workplace teaching and learning, which is recognised as advanced standing into relevant tertiary postgraduate programs. To support recruitment and workforce development of registered nurses employed within Queensland Health facilities through the provision of educational programs that are portable and flexible and foster the attainment of relevant competency standards. The program is delivered through self-directed learning modules. All modules are mandatory and are completed in a sequential manner, covering core knowledge and skills required to care for diverse cancer care populations: population health, cancer biology, diagnosis and classification, treatment and planning, supportive care, treatment modalities, and oncological emergencies. Registered nurses intending to seek advanced standing towards a relevant postgraduate program are required to complete all components of the program, that is, all module activities and assessment items within a 12-month timeframe. The academic industry partnership between Queensland Health and the Queensland University of Technology is an extension of the University Industry Integration Cancer Care Transition Support Program. Partnership between Metro North Health, Metro South Health and Queensland University in Technology in 2021 to work in collaboration to lead an academe industry integration research project in cancer care postgraduate education, and it is the first e-learning transition support program developed and managed in partnership with Queensland Health and the Queensland University of Technology. We have a number of supporting guides and education tools to support nurses on their journey of lifelong learning, and it underpins much of their career decisions in regard to expanding their scope, but also to support their leadership development and clinical governance proficiency, and also supported by their peers and other experts around clinical supervision. We've progressed to ensure that services within Queensland to ensure cancer care is provided as a place-based service for our communities. And as mentioned, much of that care is provided by Queensland nurses, nurse practitioners, and advanced practice clinical nurse consultants. Thank you for your time today.
Thank you, Dr. Nolan, for such an informative presentation on advanced practice nurses and nurse-led, how we can see that how world is going towards the nurse-led interventions, and because research has proven that nurse-led interventions can improve patient outcomes. So thank you for sharing different roles of nurses, be it is nursing assistant and or nurse practitioners based on the credentials they achieve, and how workforce sustainability through how workforce can be made sustainable through overcoming different structural and contextual barriers. So moving forward, for today we have 4 free papers. So let me invite Ms. Nabila Parveen from Shifa College of Nursing, Islamabad, Pakistan. She will be presenting on the topic of effect of simulation-based intervention on the practices of nurses regarding the handling of cytotoxic drugs in Tertiary Care Hospital, Islamabad.
Bismillahirrahmanirrahim. Assalamu alaikum and very good morning to everyone. And Assalamu alaikum Lahore as well. I am Nabila Parveen from Shifa Amir Millat University. I am MSN second year student. Thank you so much for giving me the opportunity to present my study here. The title of my study is The Effect of Simulation-Based Intervention on the Practices of Oncology Nurses Regarding the Handling of Cytotoxic Drugs. These are the outlines of my presentation. Cancer is a growing global health threat with 19.3 million new cancer cases worldwide and 8.18% million new cancer cases in 2022 in Pakistan. Cytotoxic drugs, which are also known as CDs, used for the treatment are a beacon of hope in this situation. Despite cancer spreading rapidly and despite the therapeutic benefit of the cytotoxic drugs, these drugs pose significant occupational risk to healthcare professionals due to their carcinogenic, mutagenic, and teratogenic properties. Nurses routinely handle CDs through transportation, storage, administration, disposal, and spill management. Nurses are at the higher risk of occupational exposure due to these drugs. This exposure can occur through the skin absorption, inhalation, and ingestions. The literature reveals that nurses have poor practices regarding the handling of cytotoxic drugs. To improve these practices, multiple interventions have been conducted, like PowerPoint presentation, group discussion, and utilization of mobile applications. Most of these interventions focus on the therapeutic aspect of the handling CD, neglecting the hands-on practices. Therefore, this study aimed to evaluate the effect of simulation-based intervention on the practices of nurses regarding the handling of CDs. My research question: what is the effect of simulation-based intervention on the practices of nurses regarding the handling of CDs? A single group pre-test, post-test COSI experimental design was utilized in a private tertiary care hospital on 59 oncology nurses. The duration of the study was April to September 2024. Nurses who were directly involved in the handling of cytotoxic drugs were the part of this study, and the nurses who were on the more than 15 days leaves were excluded. Here is the recruitment process. Data collection tool. A self-developed observational checklist was utilized for this, which is developed on the basis of NIOSH guideline and USP chapter 800. And the finding of Naseem et al. Study, which was previously conducted in the same setting in 2023, was also utilized for the guidance. The tool comprising of two sections, demographical part include age, gender, qualification, unit, experience, and the previous training in the CD handling. And the section 2 involved the CD handling practices like routine handling of the CD steps, which are 18 items, which have 3 subsections. Pre-administration have 3 items, during administration have 6 items, and post-administration have 9 items. And then CD spill management have 16 items in it. Nurses' performance considered satisfactory if they are equal to 80% or more than 80. And response rate was collected by using 3-point scale, yes, no, and not applicable. CVI of this tool was 0.95. Okay, here is the ethical consideration. Okay, observation was collected by the research assistant, and he collected the baseline observation, and the data was collected by using non-participatory observation method. Each nurse was observed 3 times, and soon after the completion of the baseline data, primary investigator has initiated the intervention. And that intervention, she utilized strategy, demonstration and written demonstration in this intervention. Demonstration by the primary investigator and written demonstration by each participant for each step. And a checklist was utilized for this to maintain the consistency of the step. 3 weeks after the intervention, of the completion of the intervention, research assistant started to collect the post data, which is by the following the same process as the baseline data. Okay, data analysis was done by the SPSS 26 version with this significance value. All demographical variables were categorical in nature, so the frequency and percentage was calculated. For inferential statistics, chi-square and Fisher-Exact test and McNemar test was utilized. Study results. If we see that most of the participants were between the age of 26 to 30, maximum were male and have diploma, 70% nurses have diploma, and maximum participation were from the inpatient. Okay, if we see that pre-test and post-test, none of the nurse got 80% score in the pre-test intervention, pre-intervention, but after the intervention, 42 nurses out of 59 got satisfactory practices. If we see the subsection of the categories, in pre-administration phase, which have 3 items in it, 23% improvement and 23% nurses have satisfactory score. Maximum improvement were seen in during administration step, which was 89.9%. And then in post-administration step, 77.9% improvement were observed. If we see the comparison of practices with the demographical characteristic, the chi-square value, p-value is less than 0.05 in the qualification. That indicate that qualification have its influence on the practices level of the nurses. Practices of spill management. During the pre-phase, cytotoxic spill occurred twice, but no proper step were followed. Therefore, the overall practices was unsatisfactory in the both observation. Notably, no spill accident were found during the post-intervention phase, and the difference between the pre-test and post-test was not computed. The difference between the pre and post finding, the McNemer test value indicate that there is a statistical significant difference between the pre and post test intervention. If we see the strength of our study, data was collected by the research assistant, and research assistant have 3 years of experience, which enhance the credibility of the research. And the checklist which we have utilized for demonstration and written demonstration serve as a guide for the CD handling practices. And this study utilized a unique teaching strategy, demonstration and written demonstration, employing hands-on training and influence the practices of nurses. The limitation, the study was confined to a single private hospital, which may limit the generalizability of the finding to other healthcare setting. The sample was small, which maybe affect the representativeness of all nurses, and the pilot testing of the study could not be conducted because of the limited nurses. If we see the recommendation, hospital should conduct regular in-service sessions. There should be strict enforcement of policies and the procedures, and regular audit should be made mandatory. Availability of the necessary resources which are required for handling CD must be provided, and research of a greater level with the larger sample, with the longer duration and the diverse health setting, exploring the factors affecting nurses, practices, occupational exposure, and the environmental contamination could be done at the later on. If we see the conclusion, the study demonstrated that a simulation-based intervention incorporating both demonstration and written demonstration effectively enhance nurses' practices in handling cytotoxic drugs. These are the references of the study. Question? Any question? Thank you so much. And I would like to thanks to my Professor Sir Muhammad Ishtiyaq, Ma'am Sadia Farhan, and Ma'am Naseem Akhtar for supporting me in this study. And thank you so much, Madam Raisa, for being here with me in this session.
Thank you. Thank you, Nabila. The next, yeah, you may clap for her. Okay. The second free paper that we have will be presented by Hafiz Sabkudullah, who is our assistant director at Shaukat Khanum. And let me inform you that all these free paper, one of the best paper is going to get Begum Mir Research Award.
Bismillahirrahmanirrahim. So the topic of my presentation is health-related quality of life and its association with perceived social support and adult breast cancer patient, which is a study conducted at Karachi, Pakistan. This is the outline of the study. So breast cancer is the second most common cancer and ranked fifth as a cause of death from all other type of cancer. It is increasingly alarming problem in lower and middle income countries where its incident rate have been raising up by 5% every year. According to the literature, approximately 1 in every 9 Pakistani women is likely to suffer from breast cancer. A systematic review from Pakistan found that breast cancer incident is 2.5 times higher than the neighboring countries, including Iran and India. So another study from Pakistan found that out of 10,000 malignant cases, breast cancer was most prevalent, that is 32% among females. On the other hand, improved screening program, early detection, health awareness, and improvement in treatment have resulted an increase in the survival rate of breast cancer patients. However, living long cannot be substituted for quality living because it has been found in the literature that breast cancer patients commonly encounter physical and psychological complications
during and after treatment. The rationale for conducting this study was that in Pakistani context, it is considered that the social support for patient is high, while it is one of the multi-dimensional approach to improve the quality, health-related quality. Also, the negative consequences of the disease and treatment lead to decrease in the quality of life of patients. So, to the researcher knowledge at the time of proposal of this study, no other study have been conducted in Pakistan on this topic. So these were the research questions in which we studied the health-related quality of life of adult breast cancer patients and its association with perceived social support of those patients attending outpatient clinics in 2 hospitals of Karachi, Pakistan. For this study, an analytical cross-sectional study design was used. Data was collected from outpatient clinics of a tertiary care hospital and a philanthropic cancer care organization. The study population was adult breast cancer patient, and a non-probability purposive sampling technique was used. A total sample of 282 participants was calculated after adjusting the non-response rate of 10%. In the eligibility criteria, so female age 18 year and above diagnosed at least 6 months before the data collection with no prior neoplastic disease before current diagnosis, and those with the ability to understand Urdu and English were enrolled in this study. For the data collection, these tools were used, including tools on socio-demographic data, perceived social support, and tools from European Organization for Research and Treatment of Cancer Quality of Life questionnaire. For content validity purpose, the tool was presented to 8 experts in the field. Pilot testing was done on 10% of the total sample size, and the relevance and clarity of the tools were established, in which all the values were found in the acceptable ranges. For descriptive and inferential statistical analysis, data was entered and analyzed using SPSS version 19. All the relevant measures were taken to maintain the ethical integrity in the study. Now coming to the results and discussion, in demographic analysis, the mean age of the participant was 47.27 years with the range of 22 to 77 years. In this study, 30.5% of the participants were uneducated and 32.6% were having high school education completed. Additionally, 26.2% of the participants were having family history of breast cancer. And all of these findings were according to the findings in other studies. So looking at the clinical characteristic, 26.6% of the participants were receiving chemotherapy alone, while 56.7% were receiving combination of treatment. In comorbidity analysis, different percentages of the associated comorbidities were found. In health-related quality of life functioning of the study participants, the overall quality of life score was 52.51, which is similar to the finding of Alawadi and O'Hary. Moreover, the mean score of physical, role, emotional, and social functioning and overall quality of life of patients were lower than the reference values by Scott et al. In their studies conducted in 2008. Furthermore, in this study, the highest functioning was in cognitive domain, which is consistent with the finding of Scott and Safai et al. In their studies. When health-related quality of life functioning were divided into poor, medium, and high category, the finding was that 58.9% of the participants had medium overall quality of life. On other functional scales, the participants scored from 36.9 to 58.9% in the high category, while only 5 to 31.1% of the participants scored in the poor category on social, cognitive, emotional functioning scales, respectively. So these results were also consistent with the findings in the literature. Symptom analysis of the participants showed that fatigue was the highest and diarrhea was the least reported symptom. Moreover, financial problems were highly reported, followed by fatigue. And these findings were also consistent according to the literature. Health-related quality of life symptom scores were divided into good, medium, and worst category. This is another category. So pain, fatigue, and insomnia were the commonly reported symptom in the medium level. Financial difficulties, fatigue, and insomnia were the worst reported symptoms. Jassim and Whiteford in 2013 reported the same pattern of worst symptoms. Diarrhea, nausea, vomiting, and constipation were least commonly reported symptoms in the study, and similar findings were also reported in the literature. In the current study, it was identified that the highest mean perceived social support was from family and lowest was from friend. Moreover, this showed that the overall perceived social support, family support, and significant other support was high, while friend support was moderate. Correlation analysis shows that health-related quality of life functioning and the overall quality of life were positively and significantly correlated with the perceived social support, while symptoms were negatively correlated with the perceived social support. All these symptoms were significantly associated except diarrhea and pain. For regression analysis, univariate and multivariate regression were done. The variables significant at the univariate regression analysis were considered for multivariate regression analysis. And after adjusting for other variables in the multivariate regression model, the odds of having high school education was 2.29 times and high friend support was 1.88 times more likely among patients reporting the high quality of life as compared to the patients reporting poor to medium quality of life. So our recommendation based on this study are breast cancer patients should be evaluated and support should be provided in physical, emotional, and role functioning. Healthcare professionals should educate the family members regarding the importance of family, friend, and significant other support for quality of life. Proper education material depicting importance of social support for breast cancer patients should be developed and provided. We also emphasize of the need of more in-depth research studies in the form of qualitative research, case control, and interventional study, which will help in more in-depth understanding of the phenomena. So in conclusion, this study identified that overall quality of life, functioning, and symptom were significantly correlated with perceived social support, and there was a strong association of perceived friend support and education with the quality of life. These are the references. Any question? Thank you.
Thank you, Mr. Hafiz, for enlightening presentation. So our next presenter is Ms. Shabnam Naseem, Team Leader, Accident and Emergency Department, SKMCH and RC. Her topic is barriers in early detection of breast cancer among female patients at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, Pakistan.
Assalamu alaikum. Bismillahirrahmanirrahim. Iyyaka na'budu wa iyyaka nasta'in. My topic today for presentation is here barriers in early detection of breast cancer among female patients at Shaukat Khanum Cancer Memorial Cancer Hospital and Research Center, Lahore. These are my outlines. Breast cancer worldwide diagnosed cases according to American Cancer Society in 2020 are 2.3 million in developing countries. There are several barriers which cause delay in identification of breast cancer: stigmatization, embarrassment, religious beliefs, unavailability of adequate healthcare facilities, and are barriers in early detection of breast cancer. And the objective of my study is to identify barriers in early detection of breast cancer among female patients at Shaukat Khanum Memorial Cancer Hospital and Research Center. Methodology used for this study, it was a quantitative cross-sectional study design, and 204 female patients diagnosed with breast cancer were recruited through convenience sampling method. Females diagnosed with breast cancer grade 2, 3, and 4 and 18 years and above were in inclusion criteria. However, grade 1 breast cancer and patients with recurrent disease were excluded from the study. For data collection, self-administered questionnaire was used. The reliability of the tool was 0.80, and the study was approved by Scientific Review Committee and Institutional Review Board of Shaukat Khanum Memorial Cancer Hospital. These are results. Demographic variables are the educational level of the population was primary to secondary were on high diagnosed cases of breast cancer. Although the population was college and university literate, but most of the cases are primary and secondary education level. Further, our population was from middle and upper class, and most of the participants belong to low socioeconomic status. In age variables, age of the participants ranged from 19 to 79 years. The breast cancer targeted women mostly from 30 to 49 years of age in our results. Demographic variables, 77.9% participants were married, 9.3% were widow, and 6.9% were divorced. These are barriers in our results. Financial insufficiency and faraway health facilities were most top barrier identified in this study. Fear of being labeled as cancer patients was 62.7%. Fear of treatment, surgery, and side effects of treatment was 62.3%. And hesitation to visit male doctors. This barrier was 59.3%. Lack of awareness was also our top barrier. Our study results show women delayed due to financial burden, unavailability of health care facilities in nearby, fear of being labeled as cancer patients, and lack of awareness. A meta-analysis identified that inaccessibility of health facilities, lack of health insurance, wrong diagnosis, lack of female doctors, and lack of awareness were key barriers in early detection of breast cancer. Fear of marital life failure and fear of treatment, its side effects, and surgery are barriers found in our research. A study in India supports our results in the same context. Our results show 59.3% women delayed diagnosis due to hesitation to visit male doctors. Women reluctant to visit male doctors, having privacy concerns, and Khan et al. In 2019 study show the similarity to our results. Women face barriers in different periods of disease, starting from diagnosis to treatment. Early detection of breast cancer is crucial to decrease mortality rate and promote survival. Barriers need to remove from journey of breast cancer of victims. Our recommendations are the awareness campaigns through healthcare workers at community level to reduce fear and hesitation among females to talk about breast cancer issues. The efforts are required by policymakers to ensure availability of breast cancer screening and treatment centers. The financial subsidies, a health card, and free diagnostic facilities can be initiated to make possible early diagnosis and reduce disease burden. Furthermore, we recommend that in our country, like Pakistan, like EPI programs and vaccination teams go door to door. And if they are educated for to create awareness in in females, so it's a very easy way to counsel and reduce fear of females to talk about breast cancer issues. Further studies can be conducted to investigate the barriers in depth. These are my references. My acknowledgements to my nursing division and Ms. Rihanna Ilahi, who made us to think like researchers and our teachers. This is message for all females.
Thank you, Ms. Shabnam. We will take question answer later. The last free paper will be presented by Ms. Ruby, who is also a nurse at the OR at Shaukat Khanum Memorial Hospital.
Okay. Assalamu alaikum to all of you. My name is Ruby from Shaukat Khanum Memorial Cancer Hospital, and this research is conducted in pair with Ms. Sonia, my colleague, and supervised by Director of Nursing, Shaukat Khanum Memorial Cancer Hospital, Ms. Rehana Ilahi. The title of this study, Perception of Spirituality Among Nurses Working at Tertiary Care Specialist Hospital, Lahore. While this presentation, I'll go through with these highlights, including background, study objectives, hypothesis, methodology section, result discussion, strengths, limitations, future implication, and conclusion. In the background, spirituality is defined as a way people find the meaning and purpose in their life and experience their connectedness to self and others. WHO and International Nursing's Code of Ethics both emphasize on the provision of comprehensive care, including spiritual care. These are the objective of my study. The first objective is to explore the level of perception of spirituality among nurses working at the tertiary care specialist hospital. And the second one is to find out the association between the nurses' demographic characteristics and their perception of spirituality. So there are two hypotheses. The null hypothesis stated that there is no association between nurses' demographic and their perception of spirituality. And the alternative hypothesis is there is an association between nurses' demographic and their perception of spirituality. So in the methodology section, a cross-sectional analytical study conducted at the Tertiary Care Specialist Hospital in Lahore, targeting the nurses working at Shaukat Khanum Memorial Cancer Hospital by using the simple random sampling with a sample size of 141 and analyzed by the SPSS. So spirituality and spiritual care rating scale was used to collect the data. This tool consisted at 17 statements rating on 5-point Likert scale. To make the operational definitions, we categorized that into high perception of spirituality, moderate, and low perception of spirituality on the base of the total score that was 85. So inclusion criteria, all the nurses working at the bedside care, working at the Shaukat Khanum Memorial Cancer Hospital with the more than of 6-month experience. And the exclusion criteria, all the nurses who are not involved in direct patient care. These are the results section. First of all, I'll go through with the demographic distribution. So the gender distribution of this study shows that 59% participants were female, remaining were male. The majority of the participants, 45%, were aged between 26 to 30  30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion in other age groups. 30 years, with a smaller proportion
In the professional education, out of 141 participants, half of the participants, 50%, having a BSN or post-RN BS nursing degree. A smaller proportion, only 3.5% having a higher degree, 3.5, remaining divided into two same proportions. So in the clinical experience, half of the participants, 51%, have a 1 to 5 years experience, clinical experience, with smaller group having less than 1 year, 6 to 10 year, or more than 10 years of experience. This is the result section. So I'll go through combined with the result and discussion. The finding of this study revealed that the majority of the participants, 90.7%, shows a moderate perception of spirituality. This suggests that the most nurses have a more balanced or average understanding of spirituality in their professional context. The previous study indicates that the nurses often regard spirituality as an essential component in holistic care, but the perception and integration into clinical may vary. Another study said that the moderate perception of spirituality may reflect the nurses' focus on emotional and the physical aspect of nursing care, although it's important, but may not be prioritized due to some specific training. According to Salman et al. 2018, the hospital setting that is most task-oriented setting and focus on acute care may limit the opportunity for nurses to explore the deep meaning of the spiritual care. The smaller proportion, that is 4.3%, shows the high perception of spirituality, shows that person may more engage with the provision of spiritual care. According to Mayer, 2020, the individuals might have received a specialized training or may personal experience to enhance to provision of spiritual care. The smaller portion, that is 5%, shows that low perception of spirituality. According to Rose et al. 2019, the low perception of spirituality may the reason could be personal beliefs, lack of knowledge, or institutional barriers that discourage to inclusion the spirituality at the practice. So according to this research that has been conducted in 2018, according to this research, address the barriers through the provision of education and training that were more likely to integrate into practice. So second objective was to check the association between the perception of spirituality and the nurses' demographic characteristics. In this research, 4 demographic was studied, that was age, gender, clinical experience, and education. By the applying chi-square test on the SPSS, we get the all p-values from p-values more than 0.05%. That shows there is no significant relationship between the nurses' demographic and their perception of spirituality. So, according to this research that has been done in 2023 and 2015 indicates that spirituality is influenced by personal belief than external characteristics. In contrast, on the other hand, these research suggested that the experience and higher education can influence, and another research indicates that the age and clinical experience can influence on the perception of spirituality. The variation of these findings may highlight the complexity of the spirituality as a personal and professional concept and highlights the need for further researches to explore. So these are the strength of study. The first is the perception of spirituality remain consistent across the different demographics. So second one is diverse demographic ensure the broad representation of the nursing population. So these are the limitation of this study. The first is the sample size may limit the generalizability of the findings, and the second one is due to quantitative research, may we miss the deep insights of the participants. These are the recommendations. So first recommendation is a diverse population can make more better understanding regarding the spirituality. And the second one is longitudinal study could explore deeply with the modification with the time. So conclusion is spirituality is a vital tool for comprehensive patient care, and nurses can address spiritual needs regardless of their own demographic characteristics. Spiritual beliefs are consistent among the nurses, emphasize the importance of spirituality in the nursing care. These are the references. I would like to acknowledge my family, special to my husband. My institute, Shaukat Khanum Memorial Cancer Hospital, to provide us this platform to present, and all mentors and advisors and all collaborators who participate in this study. Thank you.
Thank you, Mr. Ruby. So before we move ahead for the QA session, I would like to invite Dr. Raisa Gul. She is professor in Dean College of Nursing, Shifa Tamil Millat University, to please come and share your invaluable thoughts with us.
Bismillahirrahmanirrahim. All the committed leaders of healthcare and enthusiastic learners, Assalamu alaikum and a very good morning. First of all, thank you very much for giving me this opportunity, which is not part of the program, but you created that provision for me to share my thoughts and views being here. I must say that, you know, I thoroughly enjoyed the program, and it was not the first time. I am a consistent participant for the more than a decade. I started coming here since 2013, and I'm very pleased to see the consistency as well as the improvement in the program. It's always very well thought and well executed on a variety of topics, and excellent speaker. So I would request a big hand for all the organizer, because you know what you see here, the few hours show, it requires a lot of thinking to have such a program which has this richness and diversity. We learned several things. I myself, I must say, it was always a learning experience. I would like to highlight two things. I think one thing we learned that there are a wide array of opportunities for research and services in general, but particularly in cancer care. Another thing that we learned, which I think, if we compare with some of our seasons researcher who presented here, and if we look at our young growing researcher, we are still very new in this area. So we have to go a long way. And we are learning the thing that we need to keep in mind, that knowledge, it should not be a random activity. Mostly we do research, and please excuse me, I'm not saying all, but majority that I interact with, usually they will say, किस पे research करें, ठीक है? करना किस पे है? They get admission even in the master's program or even a time in doctoral program, but they are not very clear what they need to research on. So research is not only for knowledge production. I think yesterday and today we learned it very clearly that it is for a purpose. It should be, it should have a goal, and the goal should not be only to get a degree or get a promotion or high pay, but how our research will impact on the patient care outcome. And I think you learn several concepts. And I will also request Professor Kui, both the lectures or the talks that you had, the one you had yesterday and today, that we request you for a webinar. And I will, to interact with a broader population. May I ask how many of nurses here are other than Shaukat Khanum? आप लोग हाथ ऊंचा करें, मैं देखूं थोड़े शौकत खानम से. So that's very good. That's very good. So you had a good opportunity to learn from what was presented to you. हो सकता है कुछ concept ऐसे हो जो आपके लिए नए हो, उसमें और पढ़ना पड़े. लेकिन एक मैसेज तो बहुत क्लियर है कि जब आप रिसर्च का सोचें तो अपनी प्रैक्टिस के बारे में सोचें. So the very important message that we have, one is that when you are thinking about research, you can begin reflecting, first of all, critical observation on what we do, how we do, why we do, and are we achieving the intended outcome of our actions and the unintended outcome, right? So the concept that we learned that, the implementation, but also the de-implementation. So the de-implementation can only be implemented if you critically observe what we do and also reflect on what we do. और जो हमें अपने एक्शन से चाहिए, क्या वही हो रहा है या नहीं हो रहा, और जो हमें नहीं चाहिए, क्या वो चीजें भी हो रही हैं. ठीक है. So that's very important. So observation, reflection, and questioning, very, very important thing. I think जो research की शुरुआत है, that is from question. अगर हमें अच्छा सवाल बनाना आ जाए ना, तो रास्ते फिर बहुत सारे निकल आएंगे. ठीक है. With that, I will say thank you very much for this opportunity for me to interact with you. Thank you very much.
Thank you, Dr. Raisa, for your great reflection and always learning for us. Now it's time for the audience. If they have any questions, they can raise their hands and our team can facilitate you to come to the mic and ask the question, please.
I would request the presenters to please come on the stage so that if audience have any question, they can answer. The presenters, okay.
Mr. Hannah, they will be needing mic to answer if they can come. Okay, okay.
Have mics here. यहाँ पे भी यहाँ है. Come and introduce yourself and pose your question, please.
Yes, so we have two hand raised. Yeah, Shahid, you can go ahead, then Rabia.
Hello. Assalamu alaikum. I am Muhammad Shahid Riaz, working as a senior nursing lecturer practitioner, SKM ICU. My question is that from Ruby, what inspired you to study perception of spirituality? Thank you.
Because as an oncology nurse, we find the patient with these emotional and spiritual needs. So this study can help to fill this gap. First of all, knowledge gap. Moreover, we are covering this in this study, the association with the age, gender, clinical experience. This study can help to fulfill this gap to find out these things.
My question is for the Ruby.
Yes, please.
Could you please tell us why the certain nursing roles like leadership were excluded from the study?
In our study, we excluded the leadership roles, including director of nursing, assistant director of nursing, NLPs, and all the leadership roles that are not directly involved in patient care, because we get the clear and thoughts from the nurses who attend the patient, who build the relationship direct to the patient. So we just find out the perception of spirituality of nurses that provide the direct patient care.
Thank you.
Basharat, you can come up and ask your question.
Yes, Assalamu alaikum. So my question is to Professor Noshi Swe. So in Pakistan, we see a trend that most of the research is being done by nurses in academia, whether they are graduate students or faculty members. Is this the same trend in China, and how we can improve that more nurses in clinical practice, they also involved in research?
Thank you. This is a good question. Yes, this is the same in China. Most of the nursing research are done by professors in universities, particularly. But I see there are more and more clinical nurses are involved in nursing research. I think one of the big driver of this is we connect research with their promotion. So they need publications to be qualified for a certain promotion. And some nurses, I think because of the enhancement of critical thinking, sometimes they are not satisfied with what they are doing currently, and they are thinking, they found questions and they want answers, and they cannot find answers from their senior leaders or from textbooks, and they are turn to research as a solution. So there are more and more nurses are doing this. I presented yesterday as the drivers for research impact. I think these are drivers for nurses' participation in research as well. We have systematic, we have factors at system, sector, institutional, and individual levels. If we want to motivate nurses to participate in research, we can work on these factors to achieve our goal.
Thank you so much.
Thank you.
My name is Amrosia Heather, and I am post-RN oncology student. My question is related to Ms. Shabnam. In your study, the exclusion criteria is grade 1 patients. So why are you excluded these patients?
Actually, if a patient diagnosed in grade 1, the output and treatment and survival rate is very good. That's not so delayed. But as a female fall to grade 2, 3, 4, and further that fall in delay detection of breast cancer.
But these patients are also have the barriers related to breast cancers. They can also.
Actually, my study was over detection of barriers in delay diagnosis. Okay. Early detection. My topic was actually early detection. So grade 1 fall in early detection.
Yes, you mean sometimes the grade 1 is detected with the screening.
Yeah.
During the
Yeah.
screening. The other researcher of the same study, maybe she want to clarify. Yeah.
Yes, Farida.
Like just she mentioned earlier, because early detection, in our definition, early detection is if a patient is in the stage 1, that would not be included or considered as the early detection. वो early था तभी तो detect हुआ, ठीक है ना, तो इसीलिए.
Thank you. Yes, ma'am, understand.
Assalamu alaikum. My name is Hamza Javed. I'm a pharmacist by profession. My question is with you, sir. While explaining the inclusion and exclusion criteria in your research paper, you said you have selected only those patients who were efficient in Urdu and English. So my question is that the most of the patients who gave a visit to the hospital are from backward or rural areas. So isn't the language is a big concern or barrier in the authenticity of your research?
Yes, your question is absolutely, I would say it is a question mark in our hospital if we conduct this study in our hospital specifically. But this study luckily was not in our hospital at Shaukat Khanum. It was in Karachi, and mainly we did not encounter any such patient having language barrier. So if we would have it, had it at that time, I would have reported it in my study. So as a national language, Urdu is somehow can be comprehended by anyone. So I think that was the main criteria for us. And we did not encounter any such participant having language issues. Thank you. Thank you, sir.
Assalamu alaikum. My name is Khairul Bashar. I am from Shaukat Khanum, OA. My question from Professor, the implementation research limitations to the sample size was very small in confounding difficulty in controlling variables. So how to manage to sample size very small to the implementation research? So what approach or what strategy will be used so the implementation research with a sample size difficulty and these limitations?
So your question is about sample size for implementation research.
Yes.
That's a very good question. Implementation research is also a type of interventions research. So we need to have our primary outcome and secondary outcomes, and we need to calculate the sample size based on the effect we would like to achieve based on the primary outcomes as a regular RCT. You know that for regular RCT, we need to calculate sample size based on the effect size we would like to achieve or we expect to achieve based on literature. And then you have this effect size, you have alpha value, beta value, and then you can calculate the sample size. If you couldn't get enough sample size from one hospital, sometimes we need to do a multi-center study to achieve the sample size. Do I answer your question?
Yes.
Yeah, thank you.
Yes, Ms. Salma.
Assalamu alaikum. My name is Salma and my question is from Ms. Nabila. Ms. Nabila, have you conducted the root cause analysis that why the spillage incidences were so high?
Actually, I have 5 years of experience of working in oncology ward, and during this experience, I have observed that multiple time nurses are involved in the practices which are directly pose them to the cytotoxic drugs hazards. So that was the reason to conduct that study or thinking in this way that I could find out the reason why nurses are practicing such kind of the behavior. So initially, the thing which was in my mind was the lack of knowledge, and as the previous study already conducted in that same setting, that study finding was also that the nurses have good knowledge and attitude, but they have lack of poor practices in handling cytotoxic toxic drugs. So that's why with this perception, I have started this study and find out the strategy which could I use for the nurses, which can enhance their practices.
Thank you very much. My second question is from Afsab. You have excluded the patients who have the hearing problem. May I know why?
Sorry, can you repeat the question?
In your inclusion and exclusion criteria, the patients who have the hearing problem were excluded.
Patient having hearing problem. Yes. So if you look at the topic, that was association of quality of life and perceived social support. The term perception is very subjective to everyone. The researcher also need, for such patients, the researcher also need to have a grip on sign language, which we did not have. So we will not cross the limit which we cannot practice easily in our research. Definitely in every research, the researcher should have the knowledge that what he wants to study. If we do not have that knowledge, we should not we should not conduct that study actually. So the skills required for that study and for those participants would be one of the knowledge of sign language. Definitely. So we excluded them from our study.
Pardon me, I partially agree with it.
Yes.
But it might be due to the cancer itself or the treatment?
No, we did not.
Because it was excluded, so it was not looked into.
No, we did not look into the depth of that perspective.
Okay.
Initially, we thought of it, and then we concluded that we should not go into it.
Okay.
Because we couldn't find anyone having that expertise and who could have helped us. Thank you. Yes.
My name is Samiullah, working as a clinical manager in operating room Peshawar. My question is from Nabila because nobody asked you any question. That what type of simulation you use in your study?
Okay, I have utilized a simulation-based environment, and simulated drugs were utilized for this. And I have created a pharmacy in which I have kept some medicine, and these medicine were actually made by the normal saline drips, and I added Jameshiri in it, and to show that it is Adria blastina. And the other medicine which I make the syringe with the, I added some tang in it to give the color to that medicine. So simulated environment and simulated medicine were used for this.
Thank you.
Thank you. Actually, I have, first of all, a comment to Basharat when he asked the question, how we can involve more nurses in research in clinical, right? Okay, because my short memory is really short, so I first wanted to assure that, that's what I heard. I will say, one, we need to have at least some percentage of nurses with higher education to begin with in clinical, at least some, that could be one of the goal, because usually people go to academia. That is one thing. But I think more important is to reduce the dichotomy or this divide between the clinical and academia, And I will say here in Shaukat Khanum, you have an excellent model, and all other good institution should adopt this practice that educator should be involved for some days, for some time in the bedside care, because that is the place where you will have a question, and that can help you with the implementation research, and also joint appointment. As you have here in Shaukat Khanum, it's joint appointment. You have certain responsibility as an academician in teaching and learning, but you are also involved in clinical care. And this is an example that, it works. We can't say this doesn't work in Pakistan. It works in Pakistan. So a long comment, but, example is here, and that's what we need to do. I have a question to Ruby. What I learned from your study, that there was no association in the nurses' knowledge about spirituality with regards to different factors, age, education, this and that, where in literature, it does show some association. Am I right in that first?
Actually, literature has both statements. In some literature, they are showing the relationship, and in some literature, they are showing there is no relationship. But
so there is a divide, right?
Yes.
It's undecisive. We call it undecisive in literature. I would like to know that in your tool, is there or was there any guidance in your tool that when people were responding to your survey or your questions, that they knew the difference between religion and spirituality? Did your tool provided that clarity to your participants?
No, it's not included in tool. Our tool actually is a validated tool to measure the nurses' spirituality and spiritual care. So this tool have a subscale, 4 subscale, including spirituality, spiritual care, religiosity, and the 4th and last is personalized spirituality. So this tool is consisted different type of question, 17 questions. So there is no specifically defined that this is the spirituality and this is the religiosity.
So now I have a reflective question for you. Do you think that the lack of clarity between religious and spirituality could be one factor that the literature is divided on, in this topic. It's just, even if you don't want to answer that, just think about, could that be a thing? And if this is something, then, maybe providing some clarity to the people, what do we actually mean? I know it's in the questions also, but also giving them, whenever we have some concept which are rare or which has different view or dichotomous kind of thing, that we give clarity that in this study we mean by spirituality we mean A, B, C, and not this and that, right? Thank you. Thank you.
I just want to quickly respond to Dr. Risa's comments. Thank you for these comments. I answered your question too roughly. Actually, we did the things Dr. Risa raised up. The hospitals in China are hiring more and more master-prepared nurses now. Because like 20 years ago, they didn't even want to hire bachelor prepared nurses, but now they changed their vision. They see the value in higher educated nurses. And most of our master students are in the research track. So they are prepared to be a relatively independent researcher. So that helps the clinical nursing research. And some hospitals even have created jobs for nursing research. For example, for a regular nurse, if they are good at research or they have a strong interest in research, they can have a day or 2 days in a week to do just research. No clinical work at all, just research. And some hospitals even have nursing scientist position. So they hire master students with high profile or PhD prepared nurses as a scientist to guide the research in the whole hospital. And the second comment, we are doing that as well. I'm a staff at the university, and we are required, of course, we are also motivated to do clinical practice. So currently, our university, my school required us to do at least 2-month clinical practice during our spare time, just to let the people in academia to share our insight of research with clinical person. They can share their experience with us. And at the national level, there are kind of initiative to try to bring clinical nurses and nursing research in academia together. There are certain type of grants we have to apply with applicants from academia, hospitals, and industry. We can only apply for this type of grants as long as we have applicants from all these areas. So this is also a effort to promote clinical nursing research. Thank you.
Thank you. Let me just inform you that we are very short of time, so I will take last question. And I don't want to discourage you. Don't discourage. Write your question, give it to us, and we will circulate them. Thank you so much.
Thank you, ma'am, for providing me this opportunity. I'm Tahira from Bahria Town College of Nursing. I'm qualified in MS Healthcare Management, so that's why I'll focus the KPIs. And my question is from the spirituality researcher. That did your study or does your study recommend any KPIs for your nursing managers at your organization to measure that how the young and the senior nurses are practicing spirituality? And what is the research model of your study?
In this recommendation section of this research, I explained that we can do the audits to just check out or find out the nurses' perception among spirituality, because perception of spirituality may help to provision of comprehensive care. Spirituality is the part which lesser addressed in nursing. So we can do audits or we can do the research to fulfill this gap.
So your supported KPIs are, can you mention one of them or?
We can add the training or some workshops to enhance the nurses' perception of spirituality, or we can provide the training to make more competent to nursing to provide this.
Okay, that's very encouraging that you are working on KPIs. That is motivating. Thank you very much.
Thank you. Thank you so much. Thank you, the presenters. And I think it was very thoughtful and very, engaging question answer session because we have to start another session here. So I will request the audience. Thank you so much for your engagement. I thoroughly enjoyed the session. Let's go to the tea room. Thank you.